All righty. Yes, please turn on your cameras if you're able. So we are going to get started. Thank you all for joining today's GPSF webinar entitled Research Collaborations in Ghana. We have a very special panel for you today and very excited to have them here. Really, really appreciative of the time that they've taken out to join us today. I want to welcome you all to this webinar. This will be hopefully the first of several that we will do this year in collaboration with the Ghana College of Physicians and Surgeons. Very appreciative of the rector, Professor Richard Adanu, who has been critical in putting this together. This is actually an idea that was born from him based on our conversations at this year's annual conference, the GPSF annual conference. Our keynote speaker, Dr. Adjei, gave a very compelling and engaging presentation during the conference, and that just sparked a lot of discussion, a lot of ideas on how to move the bar forward. So after that conference, Professor Adanu and I had several conversations and thought it would be important to continue that conversation. So that is why we are here today. And I don't want to waste a lot of time because we have a lot of great content. So I'm going to read the bio for each of our speakers today. Then I'm going to pass it over to Professor Adanu to moderate the session, and then we'll get started. We ask that you put your questions throughout the presentation in the chat, in the Q&A section, and then we will ask those questions at the end if there is time. So please stay engaged with us. Like I said, put your questions in the Q&A. We'll make sure that we get them answered by the end of the webinar. So without further ado, I will first introduce Dr. Alex Adjei. He is the chief of Cleveland Clinic Cancer Institute, overseeing cancer care and research across all Cleveland Clinic locations in Ohio, Florida, Abu Dhabi, and London. Wow. He's also the director of the Taussig Cancer Center in Cleveland, Ohio, and the M. Frank Rudy and Margaret D. Rudy Distinguished Chair in Translational Cancer Research at Cleveland Clinic. Dr. Adjei graduated with his medical degree from the University of Ghana Medical School in Accra, Ghana, and received his PhD from the University of Alberta in Edmonton, Canada. You have been everywhere, sir. He went on to complete his residency and was chief resident at Howard University. Following that, Dr. Adjei went on to complete a clinical and research fellowship in oncology at Johns Hopkins University School of Medicine and Hospital. Dr. Adjei has served on a number of U.S. National Cancer Institute and National Institute of Health committees. He was chair of the NIH Study Section NCRR Clinical Research Review Committee, member of the Clinical Oncology Study Section, and NCI-IRG Subcommittee A, reviewing cancer centers. He was co-chair of the Thoracic Malignancies Steering Committee at NCI from 2015 to 2022. Dr. Adjei has served on the Committee of Diagnosing and Treating Adult Cancers of the U.S. National Academies of Sciences, Engineering, and Medicine, tasked with providing a report on this topic to the U.S. government, and the NIH Center for Scientific Review Blue Ribbon Panel evaluating quality and review by oncology study sections. He's currently a member of the NCI Board of Scientific Counselors. Among his numerous awards and honors, of which he has many, Dr. Adjei has received the IDF Gazdar Merit Award from the International Association for the Study of Lung Cancer for distinguished achievement in lung cancer research and mentorship. He has a whole host of awards. I won't go through them all. I'll end by saying Dr. Adjei has focused his research on experimental therapeutics, regulatory science, and clinical drug development. Other research interests include health disparities, global oncology, and pharmacogenetics. He has published over 300 peer-reviewed articles, and he is the editor-in-chief of the Journal of Thoracic Oncology and was the inaugural editor-in-chief of JTO Clinical and Research Reports. Thank you so much for being here, sir. And then our second speaker today is Dr. Kwaku Poku Asante. He is a public health physician, like myself, and the director of Kintampo Health Research Center. KHRC is a Ghana Health Service institution and a leading center for health research in the Ghana and the African region. The center focuses on conducting multidisciplinary research to address health challenges and improve healthcare delivery in Ghana and beyond. The center's research areas cover a wide range of health topics, including infectious diseases, child health, reproductive health, non-communicable diseases, environmental health, and health system strengthening. With more than 20 years of experience in the field, Dr. Asante has made significant contributions to public health research, particularly in Ghana and various other countries. Notably, he played a pivotal role as the leader of the Ghana Randomized Air Pollution and Health Study, which subsequently sparked numerous environmental health-related investigations. Recognized for his expertise, Dr. Asante mentors students in their research endeavors over the years and has an impressive publication record with over 100 scholarly articles to his name. He's a member of the International Society for Environmental Epidemiology and the current chair of the Africa chapter of ISEE. We welcome you both. And again, I also welcome my the moderator for the session today, Professor Richard Adanu, and I'll pass it on over to you, sir.
Right, thank you, Fran. So I'll just add my voice and say we're all welcome to this webinar. And our hope is that from the presentations and from the different discussions that we have, we'll be able to open, let's say, a new chapter in collaboration, mainly between Ghanaian physicians in the US and then researchers in Ghana, so that this would benefit our people and also benefit our careers as well. So with that, I'll hand over to Dr. Adjei. Dr. Adjei would present for 20 minutes, and then Dr. Asante will also present for the next 20 minutes, and then we'll start our discussions. So Dr. Adjei, over to you.
Thank you, Professor Adanu, and thank you, Dr. Abanyie, for the invitation, and a shout out to my co-presenter, Dr. Poku Asante. Now let's see, trying to share my screen. And I hope you can see my screen.
Yes, we can, thank you.
Okay. Yeah, so what I'm going to do, I could spend hours talking about my experiences, but I thought I'll pick up one and sort of highlight the problems we faced in the past and hopefully where we are going, starting with, for instance, this webinar that we're having. I'm a cancer researcher, so my talk and examples are going to be specifically on cancer, but obviously the research can be applicable to other parts of medicine as well. So if, just a minute, if I can advance my slides. Okay, so what we are going to discuss would be, I'll talk a little bit about the cancer problem, previous collaborations that I had, but I'll just use one example, lessons learned, current situation, and then the future. So to start off, we all know this, but I think it's important to take a step back and remind ourselves that Africa makes up 17% of the world's population. So in terms of population, we are second only to Asia. I know that Europe is just 10%, and the Americas, both North and South, makes up 13%. In spite of this, almost in my area of oncology, almost all the big trials that are conducted and are supposed to be global, which lead to our treatments for cancer, are done in other parts of the world outside Africa. So if you look carefully at this, so these are 4 big trials that were done. And if we start from my left here, the green are colors of the continents where the studies were done. So you find that in Africa, it's only South Africa, the tip here. Same as the study, which is, 21 countries and only South Africa is represented. And most of them are like this, where Africa is sort of shaded out. We are not represented at all. Okay, so obviously that's a problem. And then this is a really great example. I'm a member of the International Association for the Study of Lung Cancer, and actually a former board of directors of this association. And they published this paper where they were looking at practices in pathology across the world. So again, they're calling it global. And if you look at the percentage of pathologists, they basically sort of polled. You have Europe leading 41%, North America 24%. We actually have Oceania and Middle East represented. The whole continent of Africa is left out. And so this is a problem, and I'll come back to this in the course of the talk, right? So this is the situation we have, where the global research is basically leaving us out. Now let's come to Ghana and look at our cancer problem. So these are data from 2020. I think it's probably an undercount, but at least it showed that there were about 28,000 new cases of cancer, all cancers, and 17,900 or so deaths. This is actually heavily represented by these 5 diseases. So these are the top 5 cancers in Ghana. And the percentages I show here are actually the mortality figures. It's not the frequency of the disease. So breast cancer accounts for 18% of all cancer mortality, followed by liver 14%, cervix 11%, prostate 9%. The interesting thing is that these top 4, liver and cervix, these cancers are actually preventable because most of them are secondary to viral infections for which we have vaccines. And both breast, which is number 1, and prostate, which is number 4, whilst not preventable in that sense, is actually something we can screen for, either with a mammogram or with a PSA. And if we do that, we can catch a lot of diseases early and actually cure the majority of patients. But we are not able to do that, so that globally in Ghana, the cancer mortality rate is about 66%. Most of the West, if you took all the cancers, looked at the mortality rate, it's actually like 2%. Why? Because you have a large number of cancers that are diagnosed very early. So all those patients survive. And so it actually makes the overall mortality actually quite low, even though it looks as if it's a very deadly disease. It's just because if you look at those with advanced stages of the disease, yes, then the mortality is very high. So that's the problem we have with cancer. Now I'm going to pivot and talk about when we started doing this. And so I started this about 20 years now. So I was at Mayo Clinic then, and we actually did a study, so this was a collaboration between Mayo and Ghana, and some of you might know the individuals here. I won't mention names. I'm sure you recognize some of them. And this was based on the fact that multiple visits in Ghana was meeting patients who have advanced breast cancer, so you can actually palpate the disease. Sometimes was ulcerated, making surgery very difficult. But at that time, we had really effective new chemotherapy drugs coming out. And so the idea of this study is a neoadjuvant study, give the chemotherapy to shrink the cancer so that you can have surgery. So this was patients with advanced cancer, either operable or non-operable, give chemo, and then you do surgery. And in addition to this, one of the things we really wanted to do was be able to test for estrogen receptor status. So for breast cancer, they are really positive for estrogen receptors, and you can give a hormone or they are weak or they are negative. And at that time, this wasn't being done in Ghana. All samples were being sent to South Africa. So I figured instead of us spending all this time, why don't we do the study, use the study as an opportunity to get reagents, train Ghanaians so that we can do these tests in Ghana ourselves. And so we did the study. At that time, it was novel, the first time a study like this was being done in our part of the world, and I actually had to come and give a presentation to the ethics board because they were not used to cancer studies, and we wanted to be sure that if there were toxicities from the treatment, it wouldn't be seen as something unusual. It was fully funded by a number of pharmaceutical companies who provided all the medications, paid for all the procedures, lab tests, x-rays, and all the ancillary research. With this, we're able to get resources to bring reagents to do ERPR staining for about 400 women. And we shipped freezers and supplies to allow us to do these studies in Ghana. And so a number of folks were involved. I actually named our pharmacist research nurse administrator because they did such a great job. And this is just a sense of the some of the patients we have treated. But the important thing is that we did this study to sort of build our capacity. So we had a nurse come over to Mayo Clinic to train. We had a scientist come over to train so that he could do the immunohistochemistry. We wanted to start a tissue bank. I talked about the ethics board. We set up internal processes, all the equipment and so on for us to do immunohistochemistry in Ghana. And the long and short of it is that we got the study done, trained all the people, we had all the equipment there, the ERPR that we wanted done, and so it was never done. And so we can come to that in the discussion part. So the problem where, and this is not a typo, I actually specifically did this, there was a lack of motivated, dedicated local partners. And I have to say that the nursing was superb, pharmacy was superb, the lab support was superb, the lack of engagement was more at the level of the physician colleagues. And so there were no follow-throughs. So essentially, short of me coming to Ghana and setting this up, I did everything. We had all the equipment. We have all the resources. It couldn't be done. And so, this is my story and I applied to a number of my colleagues. So what then happened was that I pivoted. So I'll show you some examples. So in general, if you think about the people who want to come to Ghana or Africa to do research, there are really two types of collaborators. There are those with their agenda, it's their research, they are basically getting a grant to do their research. They are looking for a partner in Ghana, and those are the situations where they might come, collect all the samples, send them out. When the paper comes out, you see a couple of Ghanaian names buried in the middle, all right? Now that might be okay, as long as those of us in Ghana know that this person is not just coming to help you out of the goodness of their heart. They are furthering their research. And so we also figure out a way of how we can use our resources to partner so that we get something out of it. But most of the time we don't. And what happens is that if it's a foreigner, then we are falling over ourselves to accommodate them, to work with them, give them all the support, the resources they need to take away. If it's a Ghanaian, we are not so interested. And so that has been a real problem. And so what then happens is that those of us who are doing this almost as a pet project, because this is really not our area of research as such. We have our day job, we have our own research we're doing, but we are doing this to help. When this happens and you spend all your time spinning your wheels, then what you're going to end up doing is when you're invited somewhere to come and do something, you get up and go. So I'll show you a few snippets of some of the things I've done because of this pivoting I talked about. So I'm really passionate in capacity building and training and so on. So here you see a workshop I did for clinical research, medical writing in Turkey. This is an example of actually a workshop we did in Saudi Arabia. It was also about clinical research, and this was a huge sandstorm you can see here. And that's me there in the Saudi Gap. I've been involved in workshops. This is one we did in Lugano in Switzerland, and here in the US, actually organized a program. This actually has been one of the fun things I've done, where we took minority physicians and trained them in how to do clinical research. And I'm happy to say that right now we have folks that came from this training who had faculty at Mayo Clinic, actually here in Cleveland, University of Michigan, MD Anderson. So this went a long way. And so this is here in the US. I've done a lot of things in China. Everybody's welcoming. They send folks to come and learn from you, and we help them actually develop their clinical trials. But again, the reason is that I'm not going out of my way to do this. They approach me, come up with the resources and the support to help them. And we are all physicians, we aim to treat cancer. So when you have a situation like this, well, you go where you are invited and you are welcome. And this is a masterclass we did in Singapore pre-COVID. And this is something we just did another workshop in Taiwan. I could go on and on, but I give these snippets to show that a number of the examples I've shown, the first one I showed, which was trying to do something in Ghana, was all me, with a lot of hardship and so on, a lot of time spent, and it was very frustrating. Some of the more fun ones I'm talking about are where you are invited, the resources are provided, everybody's welcoming, and it's actually a joy to do. So this has been the experience. But, if those of you who can speak Twi, there's a proverb, they say, which is that, home is home. No matter how much hardship and so on, it's your home. So after all of this, I have to say I tried, and I have a number of examples up to 2015, trying to do things in Ghana, which was very challenging. I sort of pivoted, as you've seen. But then it's your continent, you want to contribute. So actually, European Society for Medical Oncology, their previous president, Rolf Stahel, was a really good friend of mine. So we teamed up and actually started a conference in South Africa. I really wanted to move it around the continent, but a lot of the European countries were more comfortable with South Africa because they don't have to get a visa and you don't have to take malaria prophylaxis and so on. So we started 2017. I'm happy to say that a number of Ghanaian clinical oncologists have participated in this. We do it every year in February. And then, in terms of things changing, one of the fun things I've done is actually work with Jane Mensah, who is a pulmonologist in Kolebu, and we got together and put out this paper that actually is published in July about lung cancer in Ghana. You know, you might not think there's lung cancer in Ghana, but there is. And so this is a nice paper. Actually, you can look at it online. You can access it for free. And it gives you a sense of the problem of lung cancer in Ghana, where we are and where we need to be. So for instance, if you look here in this box, it gives you a sense of the number of experts we have in Ghana, 10 thoracic surgeons. Definitely, we need more pulmonologists, about 40 pathologists, clinical oncologists, and so on. And then the other thing we're doing, remember I showed you the International Association for the Study of Lung Cancer, where they had this survey globally and Africa was not represented at all. So since this is a society I have some influence in, I pushed very hard that we have to do something to put Africa on the map. So I'm happy to say that actually this January we'll have a Pan-African conference on lung cancer. This will be the first that we'll be doing, to be in Accra. And Professor Adanu, I think I mentioned this to you briefly, will certainly be contacting you because we'll want you to be part of this. And so just finishing up, I think where we are is that the future is great, as evidenced by what we are doing now. Now, for the first time, I feel like we have partners, the younger generation coming up is excited and are interested in working with colleagues. And so the advice is that there are a lot of Ghanaian experts all over the world, and they are all willing to help. They are not sure where to start. They need local partners. They may not know who to contact. So reach out to them. Let's be coordinated. Let's collaborate, and let's help Ghana, because really, if you have two experts and one is Ghanaian and one is from the other country, the Ghanaian wants to contribute. He wants to give something, but most of the time, they are not looking for anything. They don't want to build their careers. They just want to help. And so we have a lot of people who are willing to help out there. Reach out to them and let's move our country forward. And I have to give a shout out to GPSF. They are truly a catalyst, and them together with the Ghana College, I think will move us forward. And so that is my last slide, and I look forward to the discussions.
All right, thank you, Professor Adjei, for that presentation. If you can stop sharing your screen,
Sure.
that'll be cool. Yeah. So, like we said at the beginning, if there are any questions, let's put the questions in the Q&A box. We'll address that as we go along. So now we'll hand over to Dr. Poku Asante, who's the director at the Kintampo Health Research Center, to tell us what his experience also has been in terms of collaboration. Then in our discussions, we'll see how we can get a story for the future that's, let's say, nicer than the one that Professor Adjei has presented. Dr. Asante, over to you.
Thank you very much, Prof. Adanu, and thank you to the group for inviting me to speak today. Actually, Dr. Adjei, when you started speaking, I thought nothing had really happened, but I think a lot has happened, and there's a lot that can be done. And I'm excited that you're forming the Clinical Oncology Society of Ghana. That, for me, is a big start, and I think you can leverage that. And I'll speak a little bit more about that. So what I intend to do is to speak a little about our institution and what we do. And then I use one example of how we have grown from being a small unit collaborating with an international partner to become a center of excellence and then I'll share experiences of others also. As I go along, I'll be speaking about some of the things that we can do to enhance partnerships, enhance collaborations. So I lead the team at Kintampo Health Research Center. It's about 30 years old. It's one of the research centers of the Ghana Health Service. And the Ghana Health Service strategically put 3 research centers at the different ecological zones. Kintampo is in the middle part of Ghana. There is also the Navrongo Health Research Center and Dodua Health Research Center. And our work spans mainly in the Middle Belt, but now we do research across the whole country and beyond. We note that these centers were set up initially mainly for operational research, and we have grown to do various clinical trials. And this is a picture of one of our centers. What you see in the middle there is actually not a helipad, it's a tennis court that we put over there to keep well. Our goal is to look at research way beyond the Kintampo area and into other parts of Ghana and Africa. Community support has been great. Over 30 years, we've worked in good with good rapport from the community, and I just want to acknowledge that. Research teams have been in the area of health policy, clinical trials, interventions, several of them from mainly communicable diseases, and then also a few non-communicable diseases. So Lassa fever, malaria, we're doing clinical trials on sickle cell disease and also hypertension. As was previously said, we do work in family health and non-communicable disease and environmental health. And my talk would be using the example of the environmental health work that we have done. We are supported by departments. One of them is the Demographic Health Surveillance System, which leverages the community and follows them up over a period of time to be able to identify health and demographic indices that affect clinical outcomes. The research center has a clinical laboratory, data science, and others. We initially started off by a director that is Dr. Paul Arthur. Unfortunately, he passed away whilst he was working on the job. And I mentioned him to demonstrate the fact that a vision for the future sometimes starts with one person. So even though the research center was established and said located to be in the middle belt of Ghana, somebody had to take it up. And Paul Arthur did take it up, and today we're a big institution. When he died, we were mainly dealing with just one project. It was a vitamin A project. And Paul Arthur was the main person. And at the point, it was very difficult to determine what next. It was really a challenging time. Why? Because we're working with London School of Hygiene and Tropical Medicine that was mainly working through one person who had other people supporting him. And it was a telling time. It made us really think about our future and how we can provide a sustainable research institution. So since then, we've had a lot of leadership support. You see in the picture here, the Deputy Director General of Ghana Health Service, who visits regularly, the Director General himself, the local chiefs that also support us. And then we don't lose sight of the local people. You know, we have here the local chiefs and various others, the regional team and others. So that level of support helps to provide leverage for ensuring that research collaborations do proceed. Why? Because anytime we have visitors, potential collaborators, we let them know that it is not just us as individuals, or not just us as few people sitting in Kintampo working, but then we have a mandate from the leadership of the Ghana Health Service with great support from local stakeholders. Since then, we've grown to become a big institution with over 500 staff, over 20 projects that are currently ongoing, and with over 40 collaborations around the world. And we currently have diverse funding from various people. And I give shout outs to my colleagues in Kintampo who are doing a marvelous job. Next up, we're talking about how we do these collaborations. And I looked around to find some framework to guide my talk, right? And this is one of them that I found quite complex and difficult to see. But what it sought to do was to look at what people think collaboration should be like. What makes a collaboration very good? And you see this is actually a review. You see in the dark shaded areas as those that majority of papers spoke about, as in how research collaboration should look like under various themes, how the composition should be, the structure and internal processes, how the social capital should look like, and how to create demand, and also look at impact. And I'll talk about that. I found this other framework very, very encouraging. And it sort of looks at the incremental need for various themes during the collaborative process. And it goes from contacting the individuals, how to facilitate each other, to seed the partnerships and let it grow, how to develop people and develop proposals along the line, and then right through to coordinating major successes and major pursuits. And I'll speak about some of these ones. So this is a collaboration that I want to talk about. It's about a 15-year collaboration initially between two institutions, that is Kintampo and Columbia University, and it has grown to include all these other collaborators on this slide. The individuals were mainly Professor Kenny, who is here, and also Professor Usoje and myself. And initially, we met to discuss projects, and they were dealing with environmental health. We were dealing with malaria and other and vitamin A studies. And it was quite funny because we're talking about diseases that were prevalent. And here we're dealing with environmental health. So we really had to sit and interact among ourselves. We had open discussions and workshops to think about how the collaboration would look like. And also we ensured that we intentionally brought along junior faculty to interact with the senior members and also to interact with other junior faculty from Columbia University. And then there was also small investment. And these small investments are probably startup research funds, sometimes $2,000 that were used to guide the interest of the partnership. For that study, we eventually settled on a cluster level randomized control trial that looked at a cook stove intervention. We randomized people to use improved biomass cook stove, which was the BioLite, and also we used an LPG. Now, this was at a time when the use of LPG in a rural area like Kintampo was about 20%, and mainly located among the working class in the study area. And so there was a lot to be talked about, a lot to be done. That was the excitement. But our goal was mainly to translate research with fundamental questions into practice and demonstrate impact. And we had this framework and we thought that we should be able to at least take most of them. So we then facilitated the flow of research, and the key areas that we looked at were mainly to ensure bidirectional institutional visits. Here, we got our colleagues in Kintampo to go over to the US to meet other colleagues, as you see in the pictures over here. And then we got our colleagues from Columbia to come to Ghana and embed themselves into the community. And that was a telling time because it did explain to them why we needed to do, say, a stakeholder engagement, why we had to consult a chief with drinks, which hitherto somebody would have thought was bribery, why we have to do certain things. Even though we know now, as clinicians here, and as clinicians in the diaspora, times have also changed. And so I would say that we all need to spend time to understand the new things that have happened in Ghana and how we have to adapt by it. There are other things that we did, like making each other comfortable, right? And these are small things that made us comfortable with each other. Some of our colleagues that went from Ghana to the US, they got picked up by their colleagues. They had to arrange hotels for them, even though it was easy to do. When they came to Ghana, we also did the same thing. But these are small things that help to build collaborations and also that builds trust, you know. And then these modest investments to enhance physical changes, as I mentioned, was also very helpful. We then had to seed our partnerships. We had to ensure we were intentional about building a team for all proposals, testing new techniques, and sharing the joy of some of the small successes that we achieved at that time. And then came joint publications of some of the descriptive data that we did. And that was one of our major disagreements. Here we were having people from the US very comfortable with first author and then senior author, if they call it, and then junior author and senior author. But the collaboration is not senior author and junior author. A collaboration is us all sharing equitably in what we get out of the research, like publications. But we went over that. We also supported young investigators to be able to write small proposals. And here, it looked like it was a difficult thing to do. And maybe Dr. Adjei, just to mention that we also had to be very intentional to get investigators and clinical investigators to be interested in the work that we are doing. We had to take some risk. And some of those were being able to talk about household air pollution when there were other diseases like malaria. People were dying of malaria. When will people know about household air pollution? It was very far off, right? And it's similar to the cancer situation. And I saw the picture that Dr. Adjei has shown about the seasoned clinician, top surgeon in Ghana. And also you are seated with a top researcher, but a top surgeon was one of the few dealing with breast cancer in Ghana. And you can imagine the amount of time that they would use to look after patients versus used to write research proposals and attend some meetings. So we developed proposals, we wrote various proposals to do preliminary work. And for us, the NIH proposal system was very new to us, you know, quite complex to us. We're used to getting grants from the Wellcome Trust and then the USAIDs and the FATEs and things like that. And so we had to learn. And I recall one of the situations when one of our collaborators came with a specific aims page and insisting that should be the first page. And then we are saying, no, it should be an introduction page. And we went through all those things, which were learning periods for us. And then there were also times that we felt that some terminologies we have to learn. And also our colleagues had to learn. I mean, terminologies like our site in Ghana. These were found in some proposals that we had all written. And we were quick to say that, no, it's not our site in Ghana. It is our team or our collaborative team. So some little terminologies flip egos, and we also have to be aware of that. Spoke about dedicated time for doctors and research. And I must say that now there's a lot of interest in research in the teaching hospitals. The young ones are spending time to do research, but there's still more to be done. And it's because they really want to see their patients and have very little time for research. Our research institution is primarily research-driven and not clinical-driven. And the reverse is for teaching hospitals and other places. Imagine going to a district hospital where Buruli ulcer is prevalent and you want to do Buruli ulcer studies, and there's only one doctor that is seeing the surgical repairs of the Buruli ulcer cases. It's going to be a challenge. And so something has to be changed to garner the interest of the team. The other thing is to overcome organizational and cultural barriers. And one needs to understand that there's a growing change in the dynamics of the organizations in Ghana. People are more assertive. And so one needs to know and accommodate these differences in structures. So for instance, if you want to do research at a district hospital, you should be speaking to the Director General first. And the Director General is also busy with other things. And so we have to negotiate on how to get there, speak to the right stakeholders, and also get appropriate letters of support that will help. We often forget about how to manage a collaboration as a goal, but managing it is very important. And that requires frequent engagements, like frequent meetings, and also reviewing interests as they go on. And investing in administrative structures. Now, funds would go into, say, University of Ghana or any of the big universities. They have all now formed research and development directories, for instance. So one needs to engage such people, also expose them to your side of the story. You want to optimize the collaborations and ensure that they progress, and also to consider collaborations, the overall investments that one makes. And we also need to think through what the goal is. Is it because of a personal academic achievement or giving back? You know, someone actually said to me, I have only come to help. And I think that we should be looking at that and those vibes that we give when we try to do research in Ghana. To be more collaborative, to be more carry on people. And let's also recognize that we all haven't started from the same place. The difference in the bar is very huge, and it's for us to try and fill that difference, irrespective. So we did a lot of decision making, and we shared our decisions. We had to draw an organogram to describe leadership. We had to draw a strategic plan to describe where we want to go, and we review that most of the time. And as we went along, we identified and included new people to strengthen our collaboration and also to make it more sustainable. Sometimes there is some suspicion of where people come from, right? And this is, where are they getting all the $1 million from to come and do research in Ghana? And how much are they keeping in the US, and how much are they bringing to us? To us, transparency is very key. And so we actually facilitated having the sponsors of our grants to visit Ghana and to visit the community. It also was very important because then they understood why we needed a vehicle to go to the community instead of taking the tube or taking the train or community members driving to the place. And that's sort of bridged the gap. The other thing I would think is important is, again, in terms of transparency and also sharing positions, to provide adjunct positions for faculties of various institutions, adjunct in the US, adjunct in Ghana, Ghana College adjuncts, wherever, but at least to have some stakes in the institution where one is working and to leverage the skills and opportunities that are there so that we can enhance investment for long-term commitment. So we have done all these, and as at now, we have made significant joint investments, and we have recently set up a Center of Excellence, moving from household air pollution to a Center of Excellence for Climate Change, which was launched in 2024. One of the things that we struggled with was being able to train people, right, to fill the gap and to have persons go through or follow us as we go along and grow old. So we recently got a D43 grant. This is an NIH grant to help to train people and also to focus on larger teams and bring much more research funding. We have been quite honest about budgeting and sustainability, and we share budgets. Everybody sees anybody else's budget and discuss it openly. Whilst we do this, we want to broaden collaborations beyond the science. And I was very excited to hear about Doctor's thoughts about contributing to clinical care and also contributing to the research in Ghana and training. In this instance, we did the same. So we shared the benefits of research with hospitals in and around areas where we did our work, whilst ensuring that those were also used for the research. So these are fireflies that we shared. But the fireflies were also needed for our research participants in determining an endpoint, but it was used by everybody else. And we thought this was very collaborative. So since we started with very few people, we have had lots and lots of people passing through the program and or are still within the program and have progressed from being master's students to PhD students into postdocs, and they're doing very well. There are other examples I just want to quickly share. This is one between Professor Plandreau and I. We always spoke about hypertension, and then we got into collaborations with our colleagues from NYU, Ghanaians and Nigerians, and some Americans also were all in this collaboration. And it's been going for 6 years. I won't say there hasn't been issues. There's always been issues, but we've always addressed them. And we've always built capacity amongst the people that you see here as trainees. Last example from Kintampo is the collaboration with London School. This is over about 30 years now, moving from the young to the old, or the old to the young. And these are key people that started these collaborations, came out with publications, came out with PhDs and various other research outputs. And yes, there were limitations, but these limitations have changed over time. We saw the same publication thing about the Africans in the middle. Now it has changed. Now the funds are coming directly to Ghana. We are accounting for it. We have done lots of impactful research into malaria vaccine. We are training people, and that is moving the collaboration forward. This is the humble beginning from the work that was done in 1996 by the team, Dr. Paul Arthur and Betty Kirkwood. For some of you who may know, that is Professor Hatinadi, who was in the Community Health Department of KNUST, and then a few others. That study brought in a lot of logistics, and that helped to leverage the work that we were doing to greater heights. That was the first time we saw desktops in Kintampo, and you see them here. The next one is an example from my colleague, Dr. Kofi Ifa at the Catholic Hospital in Bato, and he shared these slides with me, and I asked him his thoughts about ensuring collaborations. And he says, the locals know the problem. Let them solve it, support them to solve it, help them to raise funds. Some of them should be crowdfunding. He's quite emphatic about that. And to choose right partners and to learn to say no when one is overwhelmed with work. And I like this quote from Dr. Ifa. He says, failure is an orphan, success has many fathers. But there are new potential frustrations that we'll be dealing with as collaborators from the US and also from Ghana. Things are changing. Data management and sharing policies are changing. Coordination and leadership is changing. Most funders are beginning to be careful and insistent about knowing how much of the funds go to Africa for research and what it is used for and how it's accountable, and ensuring that there's training as a package of it. So we are responding to that. We are sending our colleagues over to places where there is resources, there is expertise to learn. These are team members that went to the US for data management and sharing workshops at NIH. And we are building our own internal scientific and administrative capacity, and then strengthening other accountability capacity, and ensuring that we maintain trust with our existing collaborators and new ones. I'll end with these few slides and say that there's great opportunities that are beyond the usual anthem of Ghana dear and Ghana for dear. This is a perception. And some of these perceptions do not come from research per se. Some of them come from people's personal experiences, which are true. In fact, one of them that said to me was, oh, as for me, I'm not coming to do research in Ghana. I'm not invested in anything in Ghana. And I asked why. I said, I was building a house and I gave money to a carpenter, and the guy didn't do the work. And this it just kicked me off. And I'm like, this guy's equating all of us to this carpenter. Let's go beyond that. Let's be intentional to build capacity and also to maintain it. There is the opportunity, lots of funds from that go to the Americas, but people are beginning to think about turning this so that we have a lot coming to Africa. In terms of research, a lot of the funding for research in Africa is coming from the European Development Clinical Trial Partnership and the Gates Foundation. So we need to tap into that. Lots go for research with a little for training. In terms of annual grant amount by recipients, Ghana is receiving about $10 million. And let's face it, $10 million a year pumped into Ghana for research builds human capacity, builds infrastructure, and above all, is impactful because the research is likely to make policy decisions. Again, the burden of disease is changing. Dr. Adjei mentioned about breast cancer and pulmonary diseases. For a long time, the funds have been committed towards communicable diseases, but we think that it's likely to change. Cardiovascular diseases are killing a lot of people. Cancers are also killing a lot of people. So I'm very excited about the approach that you have taken. And I'll end here. Thank you very much.
Right, thank you, Dr. Adjei and Dr. Asante. I think from what we've heard, I mean, there have been challenges with getting collaboration in Ghana. There have been challenges experienced by Ghanaians. I think both Dr. Adjei and Dr. Asante pointed that out. But then there's also the good news that there are structures. There are research centers that have been established in our places that are primarily for research. And that's why we had Clayton Temple Health Research Center director present to us. There are centers for research. There are people who've gone through this collaborative thing and know what partners from outside Ghana expect. And I think the standards are the same. The people don't have to be foreigners. I mean, if you're a Ghanaian and you've gone and worked in a place like Mayo, when you come down, it's a certain level of professionalism that you expect. And I think people like Dr. Asante and a number of others in Ghana have come to understand this. And there's a structure together going. So with that, I'll just stop here and we'll take the question. The thing is that because it's a webinar, the participants cannot speak. So the thing should be typed out here.
I have them here, so I can read them.
Okay.
Sure. So we have three.
Yes, please go ahead, Fran.
We have three questions. Two of which really are, how can those that are listening get in contact with our speakers to collaborate? Are you all willing to share your email addresses? What would be the best way for individuals to get collaborate? And I can send that out.
Yeah, you can send that out. No question. Yeah.
Okay. And are you also okay with that, Dr. Asante? If I share your email address? Okay, great.
Sure. And we may be signposters as well.
So the other question that's in the chat says, "Dear Dr. Adjei, are there opportunities for mentorship for Ghanaian resident physicians interested in oncology?"
Sure, there are lots of opportunities, and so just contact me, and So I wanted to rush through so that we have a discussion, but that example I gave to put things in perspective and why I'm excited about what's going on, as shown by Dr. Poku Asante and so on, is that collaborative research started because I went home for vacation. I went to Kolebu, and my colleagues, classmates, and those who were behind me in medical school came to see me, and they wanted surgical supplies, right? So can I help organize some supplies for them? And I said, yeah, I can do that. That's not difficult. But instead of, putting stuff together, shipping one time, a year on, it might be spoiled, and then we have to replenish it. Why don't we start a research program? And then based on that, we can be self-sustaining, right? So at that time, my thought was, we are bringing all these resources, we are putting the infrastructure in place for research. And particularly, one of the things that was difficult to recover from was where we're shipping all our tissues to South Africa to do estrogen progesterone receptors. Back in those days, patients were paying 100 cedis to get this done. And our study was for 37 women, but we managed to get resources for about 400. So the idea was, let's get this going, charge a minimum amount, and then we can be self-sustaining. And even though all the equipment was shipped there and we brought people to train, it could never get off the ground. And part of the reason was that there was a bit of infighting who to do it and so on and so forth. So I like the idea that things have changed, and that, as Professor Adanu said, there are centers that are interested in research, and in the last couple of years, I've come into contact with a number of young, enthusiastic colleagues and so on. So just as we've been very successful in some of the communicable diseases, infections, and so on, we've done quite a fair amount of research. We've been part of the malaria vaccine. In fact, the reason we could do our clinical trial in Ghana is that Noguchi had an NIH grant. So they actually had an ethics board set up that was acceptable to the US government, because that study was through the US government. So I think that we are in a good spot, and we should take this opportunity to team up and so on. I have to say that we are doing very well in a number of areas, as you heard from Dr. Poku Asante. But when it comes to oncologists, it's still a little bit lagging. I was just at the Cancer Moonshot meeting in the White House, and Ghana wasn't there, right? Benin was there, Senegal, Uganda, Rwanda, Tanzania, about 12 African countries. Ghana wasn't there.
So we still have some work to do.
Yeah, we have work to do.
So for sake of time, and I know Dr. Asante, you have to go shortly, so please feel free to. The next question I see says, does the focus on quick rewards rather than long-term outcomes and the lack of prior examples of locals having significant success in research play a role in the reported lack of interest Professor Adjei spoke of?
So is that a comment or a question?
I think it's probably more of a comment, but it was posed as a question.
Yeah. Well, but that's not true. We've had, in a number of areas, we've had prominent Ghanaians who've done a lot of research in Ghana and have gained worldwide recognition. So in the area of medicine, there was Professor Konote Ahulu, who did some of the seminal work in sickle cell disease. In fact, he was the one who first showed that if you are a carrier, right, you are not hemoglobin SS, but you are hemoglobin AS, you're pretty normal, you could fly, and so on. Before his research, there was a lot of information about sickle cell carriers which were completely untrue, and he did almost all that work in Ghana before he went to the UK. So we've had examples. The late Professor Nkrumah, my professor who just passed, when we were in medical school, he was doing all this research on Burkitt's lymphoma. There was a Burkitt's unit in the Kolebu Children's Block, and he had field units and so on. So there have been examples and sort of mentors for us and so on. And obviously the reasons are multifactorial, but I think that there have been prominent Ghanaian researchers who've been in Ghana who should have been examples to us.
Agreed. I'm going to summarize these two questions because they sound very similar. We have two trainees who would be interested in getting involved in research back home in Ghana. So a fourth-year medical student and the second one, just somebody young in their career. What are some ways that they can get connected to doing research in Ghana at their early stage in their career?
Well, so again, like I said, they're actually, it may not be many, but there are actually a number of colleagues doing research in Ghana. So if they were listening and they were on this call, they heard all the work Dr. Poku Asante is doing, right? They don't have to go far. So get his email, get in contact with him, and get introduced to the research and so on. Yeah, so don't always see this as an immediate opportunity to go outside Ghana, right? You know, it's not like right away, this is the chance to hook up with somebody outside so that I can go there, start something, and then you work from that. Because one of the things we have to learn doing, and I think Dr. Poku Asante spoke elegantly about this, is that look at the problems you have at home. You know, if you're a medical student, what are the cases you're seeing? What are the questions you want answered and so on? Because it's quite helpful when you come up with, you know, I've really noticed ABC and I want to study it. Can you help? Rather than sort of a blank contact like I'm interested in research and I need mentorship. Try to think about the problems you have. It's much easier for all of us if you have something you want to address, and then we can work with you to address it.
Great advice.
Maybe to add to that, I would say, I mean, definitely what Papa Jay said is what it should be. That I mean, that's one of the ways. If you have an exact question, you can look for somebody who's working in that area and work with the person. But there may be some people who also are kind of like feeling around. What's the whole research animal like? So what can I do? And in that case, I would say we've had Dr. Poku Asante present to us. He has a unit where they have different research projects. In that case, you can contact this unit and maybe do like a research internship. What they might get you to do might be collection of data, field work, but it exposes you to some aspect of the research. It might be data entry or something. Then people get to see that. So I'll say for trainees, those are some of the opportunities that exist. But then if you already have a specific research question or research interest, then you can ask that specific question and they'll connect you. And Dr. Asante, he spoke about Kintampo, but like he put in his presentation, he can serve as a good link with all the other research centers, Ghana Health Service research centers, Navrongo, Dodoa, as well as the Kintampo one, and can also connect us to individual researchers who are doing things. Yeah, thanks.
Thank you. Okay, I'll read this comment and we'll see where we go with this. One attendee says, it's difficult getting involved in research in Ghana. Physicians in Ghana don't respond to mails or are largely unhelpful once they know you are coming from the United States. They've contacted several oncologists, medical and radiologic, and general surgeons on colorectal cancer screening and never got responses to mails or WhatsApp messages. At the end of the day, they gave up. It sounds like you have a direct connection right now. Both Dr. Adjei, Dr. Asante have offered their emails, and I put both their emails in the chat. So please feel free to reach out, mention that you were on this GPSF webinar and your interest. Email me. I'm happy to try to assist with some of those connections as well, and we'll take it from there. But don't get discouraged. That's the main message you want to send from this webinar today. Don't get discouraged. There are possibilities, there are opportunities to collaborate with research projects in Ghana. So don't get discouraged. Any other questions? I know we are at the top of we're a little bit past the.
I'd like to add to say that I saw the comment made that there have been bad experiences, yes. But I mean, we should avoid generalizing based on our bad experiences. I mean, if anybody has had major bad experiences, Professor Adjei, who did all that and the thing didn't build. But you realize that in his presentation, he didn't generalize. Like, physicians in Ghana don't do this. Because when you come out with that generalization, people put up some immediate defensive thing. I mean, Professor Adjei had his problems, but then he met another group of Ghanaians and was like, why don't we do this? Without coming from the fact that, hey, I've had these bad experiences. And the output was that great paper that's been published in a very great, in one of the most prominent cancer journals today. And he's gone ahead through all this to get this, what do you call it, Cancer Society meeting that he's bringing to Ghana. So they are bad experiences, but please don't generalize from them. I mean, keep trying, and it would work. But the thing now is that the institutions you can contact. You can contact Kintampo, you can contact Ghana College of Physicians and Surgeons, and then we'll connect you to people. Because sometimes when you pick individuals and contact, those individuals, their primary thing might not be research, like Dr. Asante said. And then you get this, they are not responding because the person is just concerned about taking care of their regular patients. But if you go through the institution, we can link you to somebody who is primarily involved in research. It's not every single physician in Ghana, and I'm sure it's in the US also, who is primarily doing research or primarily interested in research. Yeah.
Good point. And it's a very good point from Professor Adanu. And for the young ones to remember that the research doesn't have to be with the surgeon, or the physician specialist. It could be with the pathologist. It could be with the chemical biologist in the lab. It could be somebody in basic sciences in the university, right? Because yes, you might have somebody who's a great physician, excellent doctor, but they may not have a robust background in research. So they may not be able to guide you. The person who might actually have the research expertise might be in chemical pathology lab or public health, epidemiology, different areas like that. So think broadly, clinical research doesn't have always to be with the doctor who's taking care of patients, right? It could be with other people who do all the lab work and so on and so forth. So cast your net very broadly.
I know it looked like the email addresses were not in the chat. Everybody should see those now. Again, please.
They're in the chat.
Yeah.
The email address in the chat. Yeah.
There were two different chats, so I just posted it where everybody can see now.
Oh, two different chats.
Yeah, there's one that only we can see as panelists, and then another one that everybody can see. So I've now posted it there. Again, let me know if you need any assistance making those connections. Let's see. Are there any ongoing efforts to establish a national cancer registry in Ghana?
Yeah, well, so there have been multiple efforts in the past that didn't completely work out. And even though our conference in January is specifically on lung cancer, because the association is Lung Cancer Association, I've invited cancer registry expert who works with the American Cancer Society, epidemiologist who actually happens to be from East Africa will be there. And the plan is to talk about cancer registries and see where we are with that and see how the association can actually help us establish one, because the association as part of this meeting is looking for something that they can do. And I think a cancer registry will be a good start.
Absolutely. I am not seeing any new questions in the chat. I do want to make a few announcements before we end our session today. Thank you, first of all, thank you both, Prof. Adanu and Prof. Adjei and Dr. KP Asante for being a part of today's session. I think it was a very well-received session, and there's hope. There's hope for the future. There's a lot of opportunity, and I think hopefully that message came across to all of our attendees. Our next webinar will be sometime in November. We haven't solidified the date yet, but we will share it once we do. And that webinar will be about how to establish a business in Ghana. So we're hoping to have a representative from HEFRA, as well as some US and Ghana-based physicians who have successfully started businesses in Ghana, and just have a conversation to encourage those that are looking to do so, help pave the path for the way forward. So look out for additional information about that. I also want to remind our members that we have a membership meeting on September 22nd. We have been doing a lot of great things in these first 2 months of the year, and we want to be able to share that with you, some of the benefits for our membership, some of the partnerships that we've established, and just some of the great things that we have planned for this year. So September 22nd at 4 p.m. Make sure you come out to that meeting. And then lastly, and I want to share my screen really quickly. We have our annual conference. We're going to open up abstract submissions. So September 1st, we'll be opening up abstract submissions. The theme for the conference this year is antimicrobial stewardship in the face of emerging infectious diseases, the role of the healthcare provider. And I know some individuals thought that that was a very limited scope for a topic area for a theme for the conference. So this flyer will come out in the next several weeks, but we've given some suggestions of how to incorporate the theme within the different specialties. So look out for that. We are accepting abstracts again, starting from September 1st. Think broadly. You do not have to be limited to the theme in general. So we've given some suggestions on how to incorporate some of the different topics within the specialties in the theme and be successful. Reach out to any one of the executive board members or the educational committee members, and we'll also help you if you want assistance in trying to merge your specialty with the theme. The last thing I want to say is, if you are not already involved in the residency training collaboration teams, please get involved. Reach out to Patricia Ampadu. She's on the line. We will send out her information, but you can also reach out to send an email to the Ghana Physicians USA at gmail.com, and we'll get you connected if you're not already connected. That's one of the main things that we do in this organization, trying to provide training for our brothers and sisters back home. So if you're not already involved, please reach out. Every specialty has a group, and we want to make sure that you're linked in and ready to assist with those efforts. So with that, Prof, I'll let you have the last word.
All right, thank
Either or both of you.
Well, I want to thank everybody. It's been an exciting thing to be part of. And again, I don't want anybody to be put off by the exam. I intentionally did that. And the lesson here is that I started, gave up, and went all around doing stuff other places. But I came back home, right? Because home is home. And it's exciting to see that things have changed dramatically from when I started. So I'm pretty excited.
Yeah.
Thank you.
Right. I'd like to thank Prof. Adjei for making this time. I mean, I heard this presentation at the annual general meeting and was like, we can't leave it hanging there. We've got to take it on and make sure that the future has a better story, and would like him to lead us into this future. So linking up with KP Asante and others, Prophet Jay, would like you to get some of our, let's say, our brothers and sisters. I mean, there are many Ghanaians now who are doing all the education in the US, and you've got to connect them to those of us down here. I mean, people like you were connected to UGMS, so that made you want to come home. We've got to get those who have done all their schooling in the US to know that despite that, Ghana is still home, and despite the hardships and the bad behavior of those of us here, hey, your brother is always your brother. So let's work on that. And I'd also like to say thank you to Fran and the executive of GPSF for getting this webinar going. Let's keep it going. And I'd like to appeal to all of you who are from the US on this call that please come in your numbers to the GPSF annual meeting. I mean, we've had a conference announced. Come in your numbers to the meeting. At the meeting, we'll meet face to face and we can talk about some of these things and see how we can get good partnership going for the benefit of Ghana. That's all we can do whilst we are here. So thank you very much for this, and enjoy the rest of the day.
Thank you.
Thank you all. Take care.
Okay, bye.